Well, a warm welcome to today's talk. It's still Thursday, the 10th of March. Now, in the UK, we plan to start vaccinating children aged 5 to 11 in April, although you must say it's a bit of a lacklustre declaration by the powers that be. In the States, of course, it's basically standard practice, apart from Florida, which has well and truly broken step. And Florida is now basically recommending against vaccinating children. So what we want to do in this video is look at the evidence. What is the evidence for what the state of Florida is saying? Now let's just start off with looking at this here. So this is the declaration, guidance on paediatric COVID-19 vaccines. And they're not saying don't do it, but essentially they are saying don't do it. Based on current available data, healthy children aged 5 to 17 may not benefit from receiving the currently available vaccines. So what we're going to do is start having a look through some of the evidence that the Surgeon General in Florida is presenting. And we should hopefully come to some sort of conclusion based on the evidence. Now, this is from Florida Health, healthiest state in the nation. Okay, everyone wants to be that, and that's great. Now, here's some of the things that they're saying. It is essential that healthcare practitioners review all data. Well, this is just so patently true. Of course it is. A big part of the problem here is that people have been agenda-driven and not data-driven. We have to go by the data, so there's nothing to disagree with at all there with what the Surgeon General is saying. To evaluate risks and benefits unique to each patient. So this is what I've been teaching my students to do ever since I've started teaching. We need to assess, plan, implement and evaluate care for the individual patient. We don't go and say, well, everyone on the ward will have a bed bath followed by an injection. Of course not. It's got to be individualised to the patient. So again, nothing to disagree with what Florida's saying here. When determining what healthcare services to provide, of course, and we must always do no harm. This is the fundamental axiom of healthcare. We must not harm the individual. It's not that we mustn't harm most people. We must plan the care for the individual and not harm the individual. So really pretty impossible to disagree with these opening statements, really, including the administration of COVID-19 vaccines. Well, of course, it has to include absolutely everything, of course. So the preamble all makes perfect sense. Moving on, these decisions should be made on an individual basis. They actually really spell this out. So again, nothing to disagree with. Well, I was going to say there should be no healthcare provider in the world would disagree with this, but we have been using a one-size-fits-all policy in terms of vaccination and a lot of the management strategies, and it goes against what I understand to be the best way to do healthcare. Risk of administering a COVID-19 vaccine to healthy children may outweigh the benefits. So they're not saying don't do it. They are being cautious here, but this is what it amounts to. Healthy children aged 5 to 17 may not benefit from receiving currently available COVID-19 vaccines. Okay, so they may not. Children with underlying conditions are the best candidates for vaccine. So they are saying that children with underlying health conditions might still need a vaccination. Now, let's look at the evidence that's being presented here, because this is the key thing. And I've tried to break this down into the main things that they're saying. So the first one is risks that may outweigh benefits among healthy children with no underlying comorbidities. So they're saying risks may outweigh the benefits for the individual child. And they say there's limited risk of severe illness due to COVID-19. So this is true. There is some risk, but it's uncommon. So this takes us on to this first paper here that they are using. And it's New England Journal of Medicine. It's a recognised peer-reviewed paper about the clinical trials. So let's see how they read it. And of course, it is very much about how you read these things. You can't argue with the numbers, but you can highlight particular parts, or you can sort of downplay particular parts. It's hard to be objective about a whole paper, but we're going to try and do that nevertheless. So evaluation of the BTA, that's the Pfizer COVID vaccine for children aged 5 to 11, New England Journal of Medicine. Now, the key thing here is that this data was recorded in Delta times. And my argument is that we are not in, well, of course, we're not in Delta times now, we're in Omicron times. And this has really, in my view, really changed the risk-benefit analysis. So what I was talking about 6 months, a year ago is not what I'm talking about now. Of course, we've got to move with the evidence and we've got to move with the change. And the move from Delta to Omicron is a massive change for the good. It's a beneficial change in virtually every aspect. Although COVID-19 is generally milder in adults than children, direct quote from the paper, severe illness and long-term complications, including multisystem inflammatory syndrome in children, can occur after primary vaccination course. So they are pointing out that these are risks, but this is based on Delta times, not Omicron times. So the degree to which we can extrapolate this, I think the Florida authorities are right to question that. Can we extrapolate this? And carrying on with this paper here, 2 doses of Pfizer vaccine or placebo. So this was the clinical trial basically, wasn't it? So some people got 2 doses of the Pfizer vaccine and other people got the placebo. Now, this is what you call an open label study. Now, an open label study is the exact opposite of a double-blind study. It's not the best way to do research. So in a double-blind study, the person getting the drug or the vaccine doesn't know they're getting it, and the person giving it and the person assessing the results, none of them know what they're getting. But in an open label study, everyone knows. So that does really kind of change the benefit of the balance of the placebo effect, really. But that was what they did. Anyway, they end up with 2 groups that they can compare, which is it's a 2-group comparison, that's for sure. They had 2,268 children. Now, of course, this trial, we could spend the next hour looking through this. It would be a bit boring because I think we've probably done it before. But obviously, it showed vaccine efficacy, at least in the short term. It showed relatively safe vaccine profiles according to this data in the paper. But, and this is the argument that Florida are making, no cases of severe COVID-19 or multisystem inflammatory system in children were reported in this cohort. Some of whom got the vaccine, some of whom got a placebo. Now, the whole point of doing a trial where you've got the experimental group that's getting the vaccine or the drug and the placebo group is you're looking for differences between these groups. And no cases were reported, no severe cases or multisystem inflammatory syndrome in children were noted in the vaccine group. But there again, they weren't in the placebo group either. So the argument that the Florida authorities are making here is there's no difference between the 2 groups here. There's no difference because there was no severe cases of COVID or multisystem inflammatory syndrome in children noted in either group. So if we are using that as an experiment in a control group, then we've got to say that there was no difference. So that does support the contention that the authorities in Florida are making from that particular aspect of severe disease. Now, the next one is high prevalence of existing immunity amongst children is the next argument they're making. And a lot of this comes from there's a good site here. I am going to unpack this a bit because it's a fiendishly complicated graph, but you can get one for overall there and some in age specified ranges there, which will probably take a minute to change. But I've got the main points that I want to show you. In fact, I'll just show you that now on this graphic. So here we have the graphic from that site. Now this is everyone. This is adults over 65 and children. Now there's lots and lots of different dots on these. This is because what this site does is it collects studies from all over the United States. And the different studies show much differing rates of antibodies in children, representing the existing immunity. But we do see here that there are clusters near the higher end. Now, how the same country can, well, I suppose there's different geographical areas, so it is conceivable, but I tend to think that some of these are done badly and some are done better. But we are seeing quite a lot of clusters in the higher immunity age range, and that's the one for just children there. And this is the most recent data here, where we are seeing, and it's consistent with the UK data, about 85% of children being already exposed. But here we see all these different studies, but we are seeing that, however you interpret that precisely, that children have got high levels of existing immunity. And the reason that is so confused, that graphic, is it's from all over. So these are the number of studies, so like California and state there, excuse me, apologies who live in that. It's one of the New England states, isn't it? Anyway, you can see that there's widely different amounts of studies being done in different states. That's why that data looks a bit confusing, and there's lots of data points. But we can certainly conclude, as the Florida authorities do, that there is reasonable levels of immunity already in the population. So the immunity is there already. So that's the National Institutes of Health COVID Sero Hub that we were looking at there. Absence of data informing benefits of COVID-19 vaccination amongst children with existing immunity is... I don't think I've got that paper loaded up, but it's another paper. I put the link there. That's an FDA link, that one actually. So they're saying there's an absence of data informing benefit of COVID-19 vaccine amongst children with existing immunity. Now, this is a major black hole in the data in the UK and the United States. Now, we know from data that we looked at from California and New York that people that have had 2 doses of the vaccine are not as protected as people that have had natural immunity. We know that the natural immunity actually confers better immunity in terms of preventing symptomatic infection and in terms of preventing hospitalisation. The natural immunity was better than 2 doses of vaccine, but that's only been published for California and New York. Why hasn't that been published for everywhere? Why hasn't that been published for the UK? This is an essential comparison. The person that's fully or triply vaccinated, what is the difference in their protection against someone who is someone who's not been vaccinated but has had the natural infection? And that study also showed that there was minimal, if any, benefit of vaccinating someone who had already had the infection. They didn't really get any additional benefit from that. So, again, I think I have to agree academically with the Florida study here. So in clinical trials, higher than anticipated serious events occurred amongst those receiving the COVID-19 vaccine. Now, with this piece of evidence, this claim here from Florida, if they'd actually referenced this paper before, if they'd actually referenced that one, they would have found some evidence for that. But the way it's referenced, they actually don't give good evidence for that, because this actually is only reference to this FDA site that talks about serious adverse events in general. It's not specific. Now, that's not to say the evidence isn't there, but it is to say that whoever wrote this paper made a really sloppy job of doing that referencing. But let's look at it anyway. So the severe side effects that they are concerned about: death, life-threatening side effects, hospitalizations, initial or prolonged, disability or permanent damage, congenital abnormality, birth defects, requiring intervention to prevent, permanent impairment or damage, and other serious events. Now, they are not giving any specific links between these serious adverse events, this whole series of adverse events, and childhood vaccination. It's rather linking to this generic site here. So that was a weakness in the way that they referenced. But carrying on, what other points are the Florida authorities making? What's this next one? Yeah. They do take quite a lot of information from this, which is a preprint. But it is based on New York authorities, and it is based on, you probably won't be able to see that, but that says 852,000 cases. It's based on huge case numbers. It's one of these analyses by the authorities that don't take a sample; they actually analyse everyone. So it's pretty good data, really. But anyway, reduced vaccine efficiency with Omicron, and this is the key thing. We know that the vaccines with Omicron have reduced efficacy, and we get more breakthrough infection. Effectiveness of the Pfizer vaccine amongst children aged 5 to 11 and 5 to 17 in New York after the emergence of the Omicron variant. And this is good because they are actually taking into account here the Omicron variant has now arrived, which, to be quite honest, most other authorities around the world are not. So good on New York for including that. New York State Department of Health. So, as we say, over 800,000 sample size. Here, taking the data from everyone, anonymised, of course. And it's December 13th, 2021 to January the 30th, 2022. Now, age 12 to 17-year-olds, there was 852,000 of those fully vaccinated. And age 5 to 11-year-olds, there was 365,000 of those fully vaccinated. So these are huge numbers. This is likely to give us highly accurate data. And it's in the Omicron era, which is where we are now. We're not interested so much in Delta information. The effectiveness against cases of the effectiveness against cases, people getting infected and diagnosed, of Pfizer vaccine declined rapidly in children, particularly those aged 5 to 11. So we've got a rapid decline in vaccine efficacy, is that argument. And however, the vaccination of children in 5 to 11 was protected against severe disease and is recommended. So this paper actually does recommend vaccinating children because it does say it protects them against severe disease, all being that that occurring very rarely. So a bit of a mixed data. It really depends which bit you look at there. Are you going to look at the bit where it says the vaccine efficacy declines quickly, which it does? Or are you going to say that children do get some protection against severe illness and death, or severe illness hospitalisation rather, at least, which they do, but how does that balance against the risk of the vaccine? So this paper here is saying that you're better to get vaccinated. The Florida authorities are saying they're essentially saying you're better not to get vaccinated. Now, one particular risk that they highlight in the Florida paper, in the Florida data, risk of myocarditis due to the COVID-19 vaccine. And again, we've got that in, that comes from, data here comes from this paper here, a Journal of the American Medical Association, which looks at that particularly. And quite a good data set there, December 20 to August 2021 is what that is looking at. So again, let's see how Florida is interpreting that. Study of 1,626 cases of myocarditis. So these are people that actually had the heart inflammatory syndrome. Reporting rates within 7 days after vaccination exceeded the expected rates, and we have looked at this before. We know there is an excess in heart inflammation after mRNA vaccines, and that's across multiple ages and both sexes. Highest after the second dose of vaccine, that we know. Now, in adolescent males aged 12 to 15 years, this is what they found: 70.7 cases of heart inflammation per million doses of the Pfizer vaccine. So I can't tell you to vaccinate or not. Of course, that's not my role, but I can report the data that says that the risk here was 70.7 million doses. 70.7 cases per million doses in adolescents aged 12 to 15. In adolescents aged 16 to 17, it was higher, 105.9 cases of heart inflammation per million doses of the vaccine. And in young men aged 18 to 24, it was 52.4 per million doses of the Pfizer vaccine and 56 per million doses of the Moderna vaccine. So we see the highest rate is in 16 to 17 year olds, although the rate is not insignificant by any means in 12 to 15 year olds. So that is an indication of the relative risk, and Florida clearly going down on the side of the risk is greater than the benefit. Vaccine efficacy wanes rapidly. Now this is certainly true. Study conducted out of New York, again this is that same study we looked at. New York State Department, COVID vaccine efficacy declined 84%. And this is in 5 to 11 year olds, so this is in children, this is specific to the age group. The efficacy declined 84%, that is, it went down from 68% down to 12% over 2 months. Wow, that is a rapid decline. So that is a very good argument. And again, the evidence that the natural immunity is got much better longevity is accumulating and getting, well, it is fairly strong already. So good point there from Florida, I must say. Healthy adolescents aged 12 to 17. COVID vaccine efficacy declined 40% from 85 down to 51 over 2 months. So we see that particularly in children aged 5 to 11, very rapid decline in vaccine efficacy. Now, what they do state here is for children with underlying health conditions, it's a different situation. COVID-19 vaccine should be considered in consultation with your healthcare practitioner. Well, of course it should. Hopefully you can get to a good one. Of course it should, because it should be individualised. Parents are encouraged to discuss the risks and benefits. Well, that's what this is all about. It's a risk-benefit analysis. Direct quote, in general, healthy children with no significant underlying health conditions under 16 years of age are at little to no risk of severe complications from COVID-19. For adolescents aged 16 to 7 years of age, the risk of myocarditis due to the COVID vaccine may outweigh the benefits. Pretty strong statement, really. So for adolescents aged 16 to 17 years of age, the risk of myocarditis due to COVID-19 vaccine may outweigh the benefits. They're not saying it definitely does, they're just saying may. So really, what they're saying here is they're kind of chucking it onto the healthcare provider, which you could say that's a bit of a cop-out, but you could also say this is absolutely correct because it's individualising care. So there you go. I mean, in the UK, we're going to start vaccinating 5 to 11 year olds in April. Or they're saying it can be considered as a non-emergency measure. And they're also saying that this is to guard against future variants. But we've seen that in 5 to 11 year olds especially, the vaccine efficacy declines really quickly. So why on earth would we want to vaccinate 5 to 11 year olds against a potential future variant which may or may not come? Because by the time it's come, the probability is that the vaccine efficacy will have waned potentially to the point of insignificance. So the UK strategy here doesn't really make sense. I think it really indicates the sort of vacillation that's going on in the United Kingdom. Whereas in the United States, the advice is to vaccinate that age group, but Florida has well and truly broken ranks. So there you go. I'm sorry if there's no as firm a conclusion as you'd want. All I've done is try and present the argument for and against, and I can't advise you what to do, but I think we can say that some of the Florida argument here is very good. And other parts of the Florida argument, particularly there about severe adverse events, is weaker, because as we see, that just links through to the FDA site, whereas others of their links are pretty good. That one going to work. Yeah, there you go. It takes you through to the relevant paper. So variable quality of referencing, but making some interesting points. But the key thing I like about it is that they've changed their thinking because we're now in the age of Omicron. We need to leave Delta thinking behind because we no longer have Delta, or virtually none, tiny bits, but virtually none. So there you go, interesting news from Florida, and I'll leave that to you to mull over, and all the references and links there if you want to look at it further. And thank you for watching.